we'll go ahead and get started as people kind of trickle in. Thank you all so much for being here today, and welcome to Circle Up's Interfaith Summit on Maternal Health. We are so pleased that we could all be here today as members of all different faith communities to talk about the important issues of maternal health and how we, as members of faith communities, can advocate for improved maternal health outcomes. My name is Casey Crisp, and I am the Policy and Outreach Coordinator for Circle Up. And I just wanted to start by providing just a little bit of background information about our organization for those of you who are not as familiar with our group. Circle Up is an organization based out of First United Methodist Church in Austin, and we are affiliated with the larger United Methodist Women organization. And United Methodist Women is actually the largest denominational faith organization in the world, with close to 800,000 members. And ensuring proper healthcare for women has always been at the core of its organizational purpose. And so when Circle Up was created approximately 2.5 years ago, we decided to focus all of our efforts on maternal health and related issues to work to improve maternal health outcomes in Texas and beyond. And we were guided in choosing this topic and called to this based in large part on our faith. And so we wanted to host this event today to talk about maternal health and how faith communities can help make an impact on this area and join the ongoing efforts that have been going to advocate for improvements in this area long before Circle Up was created. And so we're so excited that you could join us here for that today. Today's program is going to feature a moderated panel of really outstanding speakers. We're so pleased they could join us. And we're also going to feature some personal stories and talk about some ways that the attendees today can take next steps to get involved themselves and with their faith communities and advocating in this area. But to get us started, I'm going to have Reverend Kathy Stone, who is a pastor here at our home congregation of First United Methodist Church, Austin, to lead us in an interfaith prayer to kind of get the ball rolling. So Kathy?
Good afternoon. Please join your hearts with mine. Holy One, we gather this afternoon united by our shared faith in the ideals of justice, community, the common good, and love of our neighbors. May your spirit be present here with our speakers, listeners, and throughout these conversations around maternal health. Help us to see and hear new ways to advocate for Texas moms. May we have the strength to do what must be done in this world. May we find the courage to live our lives as lives of conviction, of spirit, of faith. May we know justice and peace in our time. This we pray in the name of all that we hold sacred, holy, right, good, and true. Amen.
Amen. Thank you so much, Kathy, for leading us in that. So to get started today, we wanted to poll our attendees so we can get an idea of where you are coming from and where your interests lie in learning more about maternal health. And so a couple poll questions should be popping up on your screen for you. Excuse me. And so if you could, we wanted you to let us know, why did you decide to attend today's event? And feel free to select all that apply. And then also, what is a skill that you could contribute to an advocacy campaign? And then in addition to that, in our chat box, if you could list at least one thing that you hope to learn from the event today, we'd love to get an idea of that as well. So I'll give everyone just a minute. Oh, the answers are coming in. It's so exciting.
Yeah.
Okay, so it looks like we have, oh gosh, you know what? I'm gonna just give it another minute because the lines keep changing. Okay, we have some interest in learning about maternal health, policy advocacy, advocating using a faith lens, interest in the speaker lineup. It looks like a really good, healthy cross-section across the board and kind of what piqued your interest about this event. And then a skill that you could contribute to the advocacy campaign, letter writing, always super important, will be especially important during the pandemic session that we're about to have in Texas. researching, calling people, talking to friends and family, sharing information on social media, and talking with my faith community. We actually have like pretty even responses all across that. So I'm super thrilled to see that there's interest in kind of a lot of different avenues of advocacy. I think that we'll be able to provide a lot of ideas on that. And everyone's being shy on the chat. So I'm sure that there's a lot of things that we're going to learn today. But we will go ahead and jump right in to the content for today. And we wanted to start today by providing not only data and information, but also personal stories to really emphasize how these are issues that are affecting at a statistical level, but also these are issues that are affecting real mothers, real families, real children. And so today we wanted to feature two videos that were created as part of the Council on Patient Safety and Women's Healthcare's Voices of Impact series. And so this was a series that the council created. The council is a group that was formed in 2011 to bring together a lot of different stakeholders in the women's health arena to work together with the goal of improving healthcare for all women. And they have created this series of videos that features some women and their personal stories with issues of maternal health. And so I'm going to go ahead and share our first video today. And this is a video that, give me 1 second, sorry, of course, Zoom is providing just a little bit of challenges. This is a video that provides the story of the Irving family. So, Zoom is always an adventure for me. Okay.
I hope you never have to read this letter. I cannot imagine you having to go through this yet again. And if you are, I am so truly sorry, Mommy. I hope you know how much I love you and how much you mean to me. I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred, but know that I would never choose to leave you. You will forever be my mommy, and I your baby girl. Shalon was my only daughter. She was loving, she was kind, she was generous. She was just always a curious child and loved to learn. She graduated from high school after skipping 2 grades. She went on to get her bachelor's at Hampton University. From there, she got a master's of science and then was accepted into a PhD program at Purdue University. She graduated with a dual PhD in both sociology and in gerontology, and she was the first student to do that at Purdue University. Both degrees were summa cum laude, and all by the age of 25. She went on to public health because she had watched her brother, who was battling MS, so she decided she'd go and get a Master's of Public Health from Johns Hopkins, and then went on to become a well-respected epidemiologist at the Center for Disease Control. Unfortunately, her brother passed away, but she still devoted the work that she did at the CDC to her brother. Shalon was a very adventurous spirit, and we had traveled to over 20 countries in the last 5 years. She just loved life. When Shalon found out that she was pregnant, she was just overjoyed. She had wanted to be a mother for so long. She went to every single OB appointment. She did everything her obstetrician required of her. She had had fibroids removed probably a year before the pregnancy. And then she found out at the time that she had factor V Leiden. So she also had to take 2 painful shots every day to keep from clotting while she was carrying her baby. Well, based on her history, her medical team thought it was best that she have a planned C-section. She was prepared, she was ready, and she couldn't wait to meet the tiny human that she'd been sharing space with for 37 weeks. Shalon had tears in her eyes. She was so excited to see her daughter, and Shalon just held her. Within 4 or 5 days after getting home, she developed a lump on her side. She started having other symptoms as well, headaches. She wasn't voiding as she should have been. Her legs started to swell. She started to gain weight. She had headaches. And every time we'd go in to see a doctor, she was just dismissed with, "You just had a baby, give it time, it'll get better." She says, "Mom, I don't feel right. There's something wrong." And I was just so concerned, but I didn't know what to do. During the last week of her life, Shalon went to the doctor 3 times for the same symptoms. On that last visit, she presented with blood pressure of 174 over 120. "Well, let me give you some blood pressure medicine and you go home and come back in a couple of days if it hasn't gotten better. But don't worry, it should be fine. Just give it a little more time." Well, after we left the doctor's office, we went and picked up her prescription and we came home. And so we were sitting there talking a little bit more, and all of a sudden, she started to have this gargled sound that came out of her mouth, and her arm shot up and she passed out. And I called 911. Probably 5 or 6 minutes later, the ambulance was there. When I got to the hospital, the emergency doctor told me that she was in pretty bad shape. I found out a couple of days later that she was brain dead because of the lack of oxygen. My cousin brought in a medical directive that I didn't even know Shalon had. And it said, "Mommy, I will fight hard, but if there is no hope, please let me go." And the next night, I happened to notice just one tear. It seemed like that came out of one eye. And I knew then what I had to do. We had her taken off life support. At 9:14, she was gone. I lost my vibrant, beautiful, intelligent best friend and daughter because she wasn't heard. I knew Shalon was a high-risk pregnancy because of her age, but I never for a moment thought that she was at risk of dying because she was a Black woman.
Okay, so we wanted to start with that personal story. The members of Circle Up found that story particularly moving, but unfortunately, not an anomaly. We've heard a lot of stories like this one, and it's just a good way to kind of center ourselves in how important this work is, and how people's lives are being so deeply affected by these issues, and how there is such a ripe opportunity for communities of faith, particularly, to raise their voices and asking for action to be taken so that improvements can be made in maternal health. So with that, I'm going to transition right to our moderated panel, who is going to provide that valuable information to us on what's going on in this area and how we can get involved. And I will turn it over to our moderator. We are so thankful to have Trevor Scott join us today. Trevor Scott can be seen weekdays currently as the host of CBS Austin's morning program, We're Austin, but he's also a very active member of the nonprofit community in Austin, with involvement in a lot of great organizations, including the Austin Child Guidance Center, Boys and Girls Club, Mobile Loaves and Fishes, and First United Methodist Church Austin. And I know that this is an issue that he feels passionately about. And so we are so happy that he could join us today as our moderator. And I will let him introduce the rest of our panelists.
Thank you so much, Casey, and thank you to the entire Circle Up group for putting this together today. I know it's a labor, but a labor of love, so thank you for doing that. And I'm so excited to be here. Thank you very much for having me. Yes, in addition to really caring about this community deeply, I am proud to be a member of First United Methodist Church of Austin, and continuously impressed and proud of the way these women step up to address this issue. And very impressed by the panelists that we have put together today, that they have put together, and I'm excited to introduce them today. I'll start with Nakina Wilson, Executive Director, Black Mamas Community Collective, a group of which I'm a huge fan, such important work happening here. As I introduce you, I'm gonna say a little bit about each of you, but we're also going to, in the chat, we're gonna drop a link to full bios for all three of you. There is a lot of wonderful things to say about you. In the interest of time today, I'm going to hit the highlights as I introduce you, but I encourage everybody to visit that bios page to learn a little bit more about our panelists today. Nakina is a native of Fort Worth, but you've called Austin home for 20 years, the first full-time director of the Black Mamas Community Collective, and has been a part of the organization since founding back in 2017. You've also served as part of the collective's leadership team, advocating for the improvement of Black maternal health within healthcare legislation and community education. And an important point here, I think, to point out, Nakina, you know firsthand the importance of this work, having received vital pre- and postnatal doula services while suffering from postpartum anxiety and depression, something very common after your third pregnancy. Please look to that bio link for more about Nakina. Welcome, and we're so glad you're here today. Scott Atnip, who is Congregational Outreach Director for Texas Impact, another terrific local organization. Scott actually rejoined the staff of Texas Impact back in 2013 after a stint beforehand in the early 2000s as an intern as the Congregational Outreach Director. So that work involves connecting the education and advocacy efforts of Texas Impact, the Texas Interfaith Center for Policy and Community Partners program, with people of faith throughout Texas, which is such important connections happening. Scott's also served as the executive director of Huntsville Promise, a nonprofit that works on youth development and housing issues, and fund development manager for the National Office of the United Methodist Action Reach Out Mission by Youth. You may know that as UMArmy, and which is a youth home repair mission organization affiliated with the United Methodist Church. Scott, thank you so much for being here and for the work that you're doing in the community. And last but certainly not least, Dr. Lori Trigo is a certified nurse midwife and nurse scientist and associate professor at the University of Colorado Anschutz Medical Campus College of Nursing. And this is a fascinating trajectory of yours, retired now in 2015 after 25 years of active duty service. You are currently an associate professor at the University of Colorado Anschutz Medical Campus College of Nursing. As a recognized nurse expert on the health of military women, you served in the 2018-2019 Distinguished Nurse Scholar in Residence at the National Academy of Medicine, where you contributed to the consensus study report, Birth Settings in America, Outcomes, Quality Access, and Choice. And boy, I bet there was some incredible information to come out of that. Welcome to all three of you. Thank you for being here. We're grateful for your time today. Dr. Trigo, we will begin with you, and I'm going to actually hand it over to you because you have a fascinating presentation for our attendees today.
Great. Thank you so much, Trevor. I am really happy to be here. I'm excited to share the information that I learned during this whole process at the National Academy of Medicine. I do refer to this as the NASAM report. So it's actually the National Academy of Sciences, Engineering, and Medicine. It was the full body that put together the report. I'm going to share my screen, so bear with me just for a sec to make sure that everything works right, of course. Okay, so as usual in Zoom, which I teach a lot in Zoom, so this is nothing new for me, but everybody has hiccups. Does everybody see the presentation page? Okay, perfect. All right, so this is the Academy setting. This study was done as part of a consensus study. The consensus study means that the academies bring together experts, and the experts make up a panel that review all of the data, literature, and information, as well as listen to voices of people who have to do with an issue. And in this case, it was outcomes of birth by birth setting. And what I mean by birth setting is the places where women birth are home, birth centers, and hospitals. This was funded by the NIH. NICHD is the National Institute for Child Health and Human Development. And it was a congressional mandate, and I'll get to that a little bit later in the report. This was the committee. These are the experts that were brought together. As a study, I was a study staff member, as you can see, and our goal was to bring together a committee that could look at all different sides of the story. So here we go. This is something that you already know. And we have the highest rate of maternal morbidity and mortality of any high income resource country. And that is really, really shocking considering the way we think our healthcare system runs. In truth, the healthcare system doesn't run the way we like to think it does. And more disturbingly, this disproportionately affects women of color, in particular Black and Native American women. There are some disparities among Hispanic women as well, and we'll get to that in a little bit. That's more on the neonatal side. Okay, so I'm just going to call it what it is. It's poor quality. This is poor quality of care that our nation is suffering from. Women there is good care places, there are pockets, and then there's bad care. But for the most part, it's not reliable. Our United States maternal health system is not a reliable place to receive OB care. And more importantly is this is what the phenomena is called too much too soon or too little too late. Too much too soon means we do a lot of stuff. We intervene in the natural process of birth a lot when it's not medically indicated. And that leads to the issues with morbidity and mortality, because every time you intervene in something that doesn't need to be intervened in, you open yourself up to more risk, more medical risk, as well as physical, psychological, and social risk. So one example of that is our cesarean section rate. You know, the World Health Organization has a world goal of a 10% of births being cesarean sections, and our country sits near 32% right now of all births. Particularly given the fact that we spend so much money on our healthcare system, this is really shocking. So let's delve in a little bit more into the disparities that we have in our pregnancy-related mortality. So we have the highest rate, particularly among the women that I mentioned before. So here's a little chart that breaks it down. Black women are 3 times more likely than the non-Hispanic white women to die within 1 year of birth. And that's what pregnancy-related mortality means. These disparities also exist in mortality rate by geographic location. So it's not just by race, ethnicity, and your social situation, but also by your geographical location. In 2016, which was the data that we used for this report, more than 5 million people lived in rural counties that didn't have, well, rural or urban, but they lived in counties that didn't even have OBGYN, a certified nurse midwife, or a hospital with maternity unit. So these are called deserts, OB deserts in our language. In 2015, the maternal mortality rate in the large metropolitan areas was 18.2 per 100,000 live births. But in the rural areas, it was almost 30 per 100,000 births. So that's almost twice as many. So then we turn to the disparities that we see by ethnicity and race for infant mortality. Mortality of infants for non-Hispanic white mothers in rural counties was 41% higher than in the large urban counties, and 13% higher than in small and medium urban counties. And I'm putting those distinguishing factors in there because I know that Texas, by the way, I lived in San Antonio for my last duty station, but I know that Texas has a mix with these couple large metropolitan areas as well as the smaller urban counties. The infant mortality rate in the rural counties was 6.5 deaths per 100 births, which is 20% higher than in the large urban counties. For infants of non-Hispanic Black mothers, the mortality rate was 12.08 per 1,000 births, and that's 16% higher in rural than in the urban counties. So we have this interesting mix of where the women live as well as race and ethnicity, and the care that they get during their pregnancy. And this is really just the stats. And so I wanted to put these in your slides. And if you need any more information, you can have that. Please feel free to ask for it. Actually, this is all in the report, and I will show you how to get to that in a little bit. So why do we have all of these disparities? According to this committee and the report, we have structural racism, biases, discrimination. These are all the reasons why we have differing quality of care, OB care among women in the United States. So a little bit about the birth settings. I want to just give you, so you know what I'm talking about here. We have home birth, and home births occur in home. They could be attended by a certified nurse midwife, by a certified professional midwife, or a lay midwife as well. We have birth center births, and that is a place where if these are birth centers, they can either be alongside the hospital, they can be within a hospital, but mostly they're alongside. And they have professionals that provide care there. They can be certified nurse midwives, certified professional midwives as well. And they have nursing, nursing RNs that also take care of women there. And then we have hospital births, and of course, you know, they have the full complement of everything. They have nursing staff, they have obstetrician staff, they have sometimes they have nurse midwifery staff, and then the hospitals vary by level. So a little bit about the location of birth in our nation. 98% of our births are in a hospital, and so that's what most people are familiar with. Only 1% of birth is in home, and less than that are in birth centers. And these are our trends over the past couple decades here of the out-of-hospital births. So as you can see, this is our total out-of-hospital births is not quite 1.6 births, 1.6% of births. Our home births are in the middle, and our birthing centers are even less. And why is this important? It's important because we need to know, because we know that births are generally safer in any place other than the hospital. And that is mostly the key takeaway of this report. The hospital is not the safest place for birth for all women. It does have to do with who attends the birth as well. So attendant of birth in 2018, we had almost 89% of births were attended by physicians and only 10% by midwives. The other is, these would probably be like at home, if you have a lay midwife, if you birthed in a parking lot and it was your partner or a medic in an ambulance. Of these midwife births, we have 92% are certified midwives, certified nurse midwives, and only 8% are certified professional midwives or certified midwives. The important thing is both of these groups of nurse midwives meet the same board certification criteria. Of the nurse midwives, certified nurse midwives, we have, most of them are done in the hospital. Most of these births are attended in the hospital, and a few are attended at home. And then of the certified professional midwives who are not nurses. So that's the difference between these two categories is these are nurses and this category are not nurses. And they mostly do home and birth center births, with a few attending. These certified midwives are the only ones who are allowed to attend birth of that group. So I want to talk a little bit about the structural backgrounds here. And to facilitate the synthesis of the information that was available to the committee, they brought together this conceptual framework that looks at the determinants of health. In this multi-layered social ecological framework, maternity experiences are shaped by the dynamic layers of that woman's social environment, from the closest layer of her family and her care team support to that wide-ranging sociocultural influences. So that green triangle at the center of the model indicates 3 elements that contribute to a positive outcome in maternity care: the access to care, encompassing medical insurance coverage and affordable care options, the quality of care, and informed choice about the care that women can make. Around that center triangle are the factors that can affect whether its elements are optimally achieved. These circles illustrate the complex sociocultural environment that shapes the quality of health and health outcomes, including social, clinical, financial, and structural factors that contribute to access and informed choice that the women have. The context and conditions illustrated in the model play an important role in health and well-being throughout the continuum of care during a pregnancy, from prior to pregnancy and conception to that year postpartum. And the context and conditions illustrated in this model play an important part. The structural inequities and biases intersect with these social determinants of health, and they permeate through all the layers of the model. They interact in complex and dynamic ways that account for why we have disparities in our birth outcomes. So here are some of the systems level factors. Structural inequities and biases are historically rooted in, deeply embedded in the policies and laws and governance of our culture. These have always contributed to inequitable treatment in healthcare system, and the health effects of racism and inequitable distribution of resources in society is being seen in our birth outcomes. Here we have the systemic systems level risk factors that are more of the social determinants of health. So social determinants are mutable, they're upstream, they're factors that influence health. They're like housing instability, education, access to education, employment, transportation. And then we have the policy and financing aspect of birth and healthcare. And this is really a significant impact, has a significant impact on why we have bad outcomes, first of all, and why we have disparities among those bad outcomes in our nation. And so each of our settings that we have talked about offers risks and benefits, but really it depends on the woman. And each of these risks and benefits in each of these places that you could have birth, you can modify it based on the risk factors of the woman herself and create more equitable outcomes. So we just have a few studies. I'm not going to dwell on this too much, but there are data limitations to how we collect the data. Those statistics that we saw earlier are a combination of birth certificate data, vital statistic data, hospital data, and not everybody collects the same thing in the same way. So there's always a little bit of doubt in whether we have accurate data. Actually, that's really a big problem in the United States, is that we don't have accurate data. So we need to look more closely at how we keep track of vital statistics and data. Where was the birth? Who was actually attending? What was the certification of the attendance? And then of course, we have such small numbers of home and birth center births that we can't really count on those statistics as representative. But we do know that women in the United States who choose that home or birth center birth have lower rates of interventions. Remember in the beginning, interventions lead to unnecessary outcomes. And they, of course, have lower rates of intervention, maternal morbidity. So those are, that makes sense, right? You don't mess around with it as much, you're not going to get as much of the side effects and outcomes. But women select home and birth center births because they want fewer interventions. But these are low risk women. And that is a risk stratification of the women themselves is incredibly important. Okay, I'm pretty sure that's not my background. So I don't know where that came from. So let's just get that out. Okay. So let's see. So what women want really is women want safety and freedom. So they want safety in where they're at, and they want freedom to be where they want to be to have their birth. And they want safety when they pick a provider, and they want freedom when they pick a provider. And that's natural. So we need to allow women to have the options and to have the choice. And this quote speaks a little bit to the difficulty that we have with collecting the data. We do have there are some data that show it's more riskier at home, and there's some data that show it's riskier in the hospital. However, it's because of the limitations. We don't really have enough births at home to study these bad outcomes to have it. So the bottom line is that most of the studies indicate that a low-risk birth can be done anywhere the woman chooses. But if she chooses to have it at home or in a birth center, she's more likely to have a better outcome. So I did put the website here for the National Academy Report. This is actually this is a separate brief that you can pull up on improving the access and outcomes. I heard a little bit about this group and how access is very important to you. And so I'll talk more now about the conclusions that the study had improving home and birth center settings. So, and I left the conclusion numbers in here. If you refer to the whole report, you can look it up by the conclusion numbers. So I left it in here. So the availability of mechanisms for all freestanding birth centers, they need access to licensure at the state level. So most of these are at state level now that I'm going to talk about. And so if your freestanding birth centers do not have licensure at the state level for certified nurse midwives and certified professional midwives, you're not going to be able to provide that care that has less intervention. This conclusion is about the inability of all of these midwives to have the same standard. Nurse midwives, certified midwives, and certified professional midwives, we all meet a global standard, and we all sit the same accredited certification exam. But nationally, we're not all recognized to practice to the full extent of our licensure. And that is why you see the breakup of who attends what and where in the places where we can attend birth. In this conclusion, we're talking about the ability to pay. And so there are a lot of good demonstration models at a state level that show that if you even out the playing field for the ability to pay, in other words, you don't have to pay. If you offer the same type of care to everybody, then you can get rid of the disparities that are seen in racial and ethnic access to care and outcomes. Ensuring that the levels of payment are adequate for the services. You have to even the playing field for maternity and newborn care across all those different birth settings. So 1, 2, and 3, home birth, center birth, and hospital birth should all get the same reimbursement. That's what this one is about. And we really do need to look at what kind of models we can create that sustain safe and effective maternity care for these underserved, rural and underserved urban. So underserved rural and urban areas themselves can also have underserved areas as well. And so that's what this category is looking at. So there are demonstration birth models of birth centers and hospital services that we could focus on, that you need to repeat these studies, the demonstration models, and that you could pull in on a state level. And really importantly is increasing the pipeline. So we need to feed our pipeline of maternity care and newborn care providers with people that look like the people who are birthing. And so this is also addressing the disparities in what we see in our the workforce of maternity care. The workforce of maternity care does not look like women of color. It doesn't look like women of Hispanic ethnicity. And so we need to make it better, as the medical field, we need to make more efforts at increasing the diversity of our our workforce as well, so that we can provide culturally congruent care to the women who receive the care from us. And just a note on policy and politics. And this was the whole background. The back setting for this study was that our maternal deaths are on the rise. Not only are we the worst of all economically developed countries, but we're still going up. And so this is really discouraging. This study was funded, as I said, by a congressional mandate, and these are the two women who are responsible for it. So this is on the left, you see Jamie Herrera Butler. She's from Washington State, and on the right, you see Lucille Roybal Allard, and she is from California. And these two women worked tirelessly to get this, to get the funding for this study into the Omnibus Act in 2018. And here's what it looks like when it finally gets into an appropriations act. And this is advocacy on a federal level. So the policy implications that we are left with there's a whole brief available on the website on the policy implications. First, we want to encourage policies that improve care across all of these three birth settings. Focusing on hospital births, we'll get 98% of the births, but obviously if we move some of those births, low risk births that could be in birth centers or at home, we could create more equitable outcomes for everybody. We can also improve each of the settings. So improving access and reimbursement in each one of those settings would be important. Incentivizing payment for value incentives for payment would foster competition and help all of the settings improve their outcomes. Lack of integration between the three settings. So if you have a birth, if you're planning a birth at home or in a birth center and there's a complication that arises, women are transferred to a hospital. That transfer is not the same in every state. That transfer is not always smooth. In fact, in rare cases, is that a smooth transfer to the hospital? And so again, in effort to even out the playing field, what you can do is advocate for policies that recognize all three birth settings and allow for smooth transfer between a home birth and a hospital birth without fear of retribution, without judgment, and without a loss of continuity of care. And we can also look at improving access to care by making those regulations and certifications for all the different types of care providers even throughout the nation. So rather than having state standards that make one midwife legal but another one not, rather than having the certification level or the content of the exam or the practices different in every state, let's make them the same everywhere and hold everybody accountable to the same standards of care. And the reason I put the Momnibus Act in there is because the Momnibus Act is a very good example of looking at ways to improve maternity care that is focused on decreasing the disparities in Black women and the outcomes for babies of Black women. The Momnibus Act is sponsored by the Black Maternity Caucus, and it actually has some very good suggestions in it. Now, I didn't list all of the acts that have been dropped by Congress because there's so many. I mean, there are hundreds of acts that are dropped by Congress just in the past 4 months. However, where they go, they're probably not going to go anywhere. So this is my politics, where policy and politics crosses the healthcare system. Those things look great, they're dropped on the floor, and then they're not going to go anywhere because they have to go to the Senate. The Senate has to approve. We all know what the outcomes of the elections are at this. Well, actually we don't, because there's a runoff in Georgia, but nothing's going to move off the desk of the Senate Majority Leader right now. So I think it's really great that this group is focused on state and local level, but you can still look at these federal legislation that's been proposed so that you can pull some of those, some of the ideas out of them and into your local. This top bullet about CMS. So this is one of those demonstration pilot projects that I was talking about. The CMMI Strong Start initiative was extremely successful, and it did increase the outcomes. It increased access to birth centers. This was done in 5 different states, and it incentivized quality care for low-risk women. So these are 2 things that you can look at to use as guidelines and create the standards in your own state. So these are just the final thoughts from the National Academy of Sciences, Engineering, and Medicine. And really what we're looking at is a wide variety of things that need to be pulled together just for this, just for maternal mortality and morbidity. And then we need to address these structural determinants and racism in our nation if we're going to do anything about the disparities in the outcomes. So thank you. Totally happy to send any of the resources your way.
Excellent. Thank you, Dr. Trigo. Thank you so much for that enlightening presentation. A lot of sobering data in that presentation. I will give you a moment to breathe and relax. We will begin now what will be the moderated panel. Typically, you would call this a Q&A, but earlier, as we discussed, there are lots of questions and definitely not many answers in this conversation. So instead, that's what we'll call it, a Q&C. This is going to be a question and conversation opportunity for everybody. And there's so much to cover here. I'll try to kind of spread the wealth with our 3 experts on the panel. I do want to go directly, Nakina, to you to begin. So much of what we just heard and so much of what we know through the work of this group talks about those social determinants, those upstream factors that factor into this situation. And that really is at the heart of the work that the Black Mamas ATX does. Can you speak a little bit more to those social determinants and how that plays into the work that you do?
Thank you, Trevor. So I definitely would say that we are addressing social determinants of health. So when we look at access, like as Lori was talking about, healthcare deserts, and we're looking at access to food and transportation and all of those things, we are providing direct service to fill in those gaps. But I would also iterate that the top tier of the structural and institutional racism is why the social determinants of health are even a thing, right? And so a lot of times you find really amazing organizations doing good work, programs that address the social determinants of health, but we'll be forever creating programs if we're not looking at the structural and institutional pieces of it. And so our organization, alongside of doing direct service, is also in the fight in regards to advocacy and research to inform different ways of addressing the problem.
Yes, yeah, excellent. Just I like the way that you put that. We could be forever creating these support systems if we're not, in fact, getting to the root of the issue. And I mean, and that's a great place to start. You know, there's that kind of terrible old saying, how do you eat an elephant one bite at a time? If we had to perhaps kind of boil it down to a specific policy priority that's related to maternal health here, where do you think a good place to start is? Scott, I can go to you there.
Sure. You know, when we're talking about social determinants, there are 800 different places that we could go to address maternal health. But from our perspective, in Texas, it has to start with Medicaid expansion because that addresses all of the different health programming for pregnant women and for all Texans, really. So for us right now, we're going to individually focus on a lot of different issues, but if there's one overarching policy priority that we would have on health, it would be Medicaid expansion, which Texas just has to do, y'all. That'd be our focus going into the next session.
Absolutely. Dr. Trigo, do you have a thought there in terms of a specific policy that really screams out?
No, I totally agree. I totally agree with Scott. I mean, Texas needs to do Medicaid expansion, and in the states where there are Medicaid expansion, so in the state of Colorado, for example, we've had Medicaid expansion. Actually, we started it earlier without the help of the Medicaid expansion legislation. We were offering it through the statewide, but outcomes are better when, okay, here's almost 42% of births in the nation are paid for by Medicaid. So, so we need to have, we need to allow that possibility for everyone and more people, especially in the state of Texas. And by allowing women to get into Medicaid prior to becoming even pregnant, then you're building, you're building a better foundation for a healthier pregnancy. So better healthcare throughout the lifespan also is going to decrease that maternal mortality that you see. So it's not just to cover pregnant women, it's to cover women and families prior to and after.
And Scott, what role for you specifically, kind of building on the theme of Circle Up and UMW at large, what role do you believe that that faith groups have in this mission and in this goal?
I think faith groups are absolutely vital to moving this conversation forward. And I'll say, as a group who works with United Methodist Women across Texas, I have used Circle Up as an example for United Methodist Women throughout the state. United Methodist Women especially, but many other faith communities will a lot of times have this clash within their groups about whether or not they should focus on mission work, where they're working in food pantries or those kinds of things, versus justice work, where they're working on public policy advocacy. But I would argue that those two, if we're doing it right, should go hand in hand. That we should be listening and learning from our communities through our mission or mercy ministries, learning about the needs of our local community, and then communicating those needs or empowering other people to communicate their challenges to those in power. And so if communities of faith are doing it right, we're getting out into our local communities, learning what those needs are, and then helping find policy solutions to meet the needs of our local communities. And congregations, churches, communities of faith are at the center of those conversations that are happening. It's where people turn when they have needs. It's where people share some of their frustrations. It's where we interact with people who are down on their luck, which all of us will be at some point in time, right? And then taking those stories and making positive change. And so I speak with usually a couple dozen different United Methodist Women's groups every year. And I think the model of Circle Up is something that congregations throughout the state should be doing, taking a local issue and really trying to figure out how to address those needs legislatively.
Speaking of those kind of legislative changes, I know that something that we're hearing definitely is a theme, and that policy is really, really important. Nakina, I might ask you something that we have also seen to be very important, which you could even consider Circle Up, at least at the very beginning, is kind of these grassroots efforts, these community efforts that maybe people are looking for ways to help that might not be legislative in nature, but kind of speaking to the community effort and something that the community collective is really working at. Nakina, talk to us a little bit about the way the community can be involved in non-legislative ways.
Absolutely. And I wanted to answer your question, listening to Lori and Scott, I would say, one of the things I absolutely believe, Lori said 42% of births are Medicaid births. I absolutely believe that is a tide that will rise all boats. I want to reiterate to that, specifically with Black women who have the worst outcomes, that it's irregardless of socioeconomic background and access to care. And so you're talking about women. Shalon clearly had private insurance. She was, probably the top 1% of those who are educated in this country, and yet that didn't matter. Serena Williams, right? Who has more money? who has better access to healthcare. And so to circle back to some of the legislative, and then I'll answer your question, sure. Trevor, some of the legislative efforts that are on the table that were alluded to earlier by Lori, when we look at the 2020 Momnibus that was brought forth by Lauren Underwood and Alma Adams, some of the ways in which there's 9 different bills that they're purporting to address the issue specifically of Black maternal health, one being investing in community organizations that are doing the work. We know that when Black women have Black doctors, they have better outcomes for both them and their babies. We know that when Black women have access to a doula, they have better outcomes for them and their babies. So investing in that way, I think there also has to be a continued push for oversight and data collection to really tell the story of what's happening, and transparency with healthcare institutions. In addition to that, the state of California, they're 2 hours behind us in time, but they're ahead in this way. They are already working legislatively to look at requirements for unconscious bias and anti-racist training, and I guess I would say safeguards within the medical profession to address the root cause of a lot of these disparities. And so, Texas, we have a lot of work to do, but I definitely think doula reimbursement is something that could be helpful. We now have a Black midwife, a licensed midwife, a certified midwife, that, I was just talking to her yesterday about whether she was going to accept Medicaid. And for her, there's no benefit, except that we know that it would give more Black women an opportunity for an alternate to hospital birthing. So I say all that to say, we certainly are doing the work. We provide free doula services, irregardless of income or insurance status. And in addition to that, we are providing free psychotherapy. Black women are 1 in 3 in terms of developing postpartum depression. And so we're providing case management. We are providing support groups. So, get behind the organization that's on the ground doing the work, but also I think, it takes all different kinds of advocates involved, to make this really move forward the way it needs to. So you can write a letter and you can write a check and get involved.
That's a great segue. One of the questions I have, and I'll open this up to the group, is, you said it takes all advocates. In your opinions, who is not at the table currently? Who are the people who do need to show up for these efforts? Is anything stand out to either of you? Yes, Dr. Trigo.
Okay, healthcare providers who are in the pipeline. So students. So I teach at University of Colorado. Of course, I teach. We have midwifery. We have nurse practitioners. We have bachelor students. Students need to be at the table, and students of color need to be at the table. And we need to encourage. This is all about that maternity workforce and the pipeline. We need to have 88% of nurses are white. So obstetricians, physicians are more evenly split between men and women now, with actually more than half of the pipeline for physicians being women, but there are still not women of color going into OB. So we need the medical students, the nursing students. We need to have representation in the education so that we can bring those people with the values and being able to learn to provide the care to women who look like them forward into the workforce, so that we can all do that. Unconscious, implicit bias, unconscious bias, however you want to call it, this needs to be an integral part of the education system, and it needs to start it needs to start in high school, and it needs to continue on through medical and nursing education programs as well. Otherwise, like Nakina said, we can make all the laws we want, and we can give people money and we can give people coverage, but they didn't listen to Serena, and they didn't listen to Ashana. So it was, it doesn't matter. We need to get people to listen.
Certainly, and Scott, while it's your work to get groups of faith to show up to the table and show up for the work, and groups like Circle Up in UMW, do you believe there is work to do in the faith community to be present?
Absolutely. There's always, we can always improve in showing up. But I also think it's providing space for people who have been impacted to be able to speak. It's one thing for me as, a middle-aged white guy to show up and talk about maternal health, but it's a whole nother to hear. And even for me, like, we can see the statistics on a PowerPoint slide, but it's completely different when you hear a woman who has experienced systemic racism or who has been harmed, or just to hear those personal stories. And so I think we need to do a better job of equipping impacted mothers, impacted populations to have a voice, and to lift up those voices when we can.
And Nakina, on a hyper local level, when we're talking about, our hometowns, our backyards, our immediate communities, where do you see a need for improvement in terms of who's showing up there?
Men.
I suspected that answer would come up at some point for sure. Yeah, I mean, exactly. It doesn't seem, although we know it is, a natural fit in terms of advocacy. Tell us more about that challenge and how we could overcome that.
Absolutely. I go to conferences and symposiums, and I would say 95% of the people in the room, or in the Zoom room, are women. And it's because, and it makes sense, right? Because we are intimately connected to the experience and the risk. However, women don't make babies by themselves, and your wives and your daughters deserve to have birth with dignity. And I say this very often, specifically for Black women: no woman should have to face death in order to bring life into this world. When you have to be faced with the proposition of, if you want to expand your family, and if you want to actually be around to enjoy your family, that's a very dim prospect, right? So men, if you love your women, stand in the gap for them. The reality is that the majority of our leadership in this country, the majority of the people who are making the decisions and who built the systems and the institutions, are men, and in large in part, white men. And so when Lori talked about us having trends that are worsening every year, right? And we have maternal mortality rates that are worse than they were 30 years ago. And of any developed, country, there's some accountability at the feet of men. And, I may be a little saying that, but it is what it is, right? So yeah.
Thank you. No, and I think that perspective is obviously very valuable, especially being on the ground and in the room, as it were, the Zoom room these days where it's happening. And personally, I just have to send a big virtual hug to the beautiful baby in the room at the moment, because it's just my nature and I can't get past it until I do. She is absolutely beautiful, Nakina. I'm glad she's joining us today. And Nakina, you and Dr. Trigo both touched on some... Oh, yes, please.
She was supposed to be in the background. No, this is Miracle. She was supposed to be in the background in her little swing, but she wanted to be center stage. So thank you for having her too.
We are glad she joined us, certainly. Now, Nakina, something that you and Dr. Trigo have both mentioned separately that I found really interesting was the issue of having accurate data. So we're looking for these big pictures, and obviously they're looking for solutions, but you both mentioned a challenge in that there isn't accurate data available. Can you explain what is behind the absence of this data and what could contribute to that? Dr. Trigo, I can go to you.
Okay, yes. So the data is limited. There's a couple different ways that the data is limited. So a lot of the statistics are from the National Vital Statistics Center. The National Vital Statistics Center uses birth certificates. So the birth certificates, list the birth and the death of people. So they're death certificates and birth certificates. So the birth certificate, first of all, it doesn't, it varies between states. Okay, so every state has a different type of birth certificate. Some of them put the provider type. So it'll just say, was there a provider available or something like that, or attended. So it's an attended or non-attended birth, first of all. So was there someone there or not? And then another way that they classify it is who was the provider? And most of them will say like family, physician or a family member or other, right? Well, there was nowhere, some of the states don't have anywhere to put like a certified nurse midwife or to put a certified professional midwife or a lay midwife. So the home birth certificates just said other, and that could have been like the spouse or the mom or somebody else attending the birth. So we don't have real accurate count of how many births and who attends births other than in the hospital. And sometimes even in the hospital, depending on how the hospital system collects the data, you could just have OB team, which could have been a midwife or could have been a physician or not. So the vital statistics themselves are very troubling. We draw conclusions from them, and they're not, we shouldn't be drawing as strong conclusions from them. Some of the states have caught up. This, believe it or not, was a 15-year effort of the states to catch up and actually put midwives. I don't think it says nurse midwife. I think it just says a midwife on their birth certificates. So that has been a change occurring over the last 15 years, but still leads us to have data that we can't really compare apples and oranges. You can't compare apples and oranges with the data collection.
Mm-hmm. And Nakina, here on a super local level, are you finding that, especially when we're talking about the disparities and the racial disparities in this conversation, are you finding that we have the appropriate data we need to kind of make movement towards solutions here in Texas, maybe even hyperlocally, specifically here in this county and in this city?
Well, the most recent data that came out in 2018 was defining maternal mortality in a certain way. And then the state came back and readjusted it. And so, there's some difference in the information that we have about, what really is happening in terms of the numbers. So absolutely, I think there's room for growth there. But I also feel very strongly, and this is Nakina speaking, that there needs to be more transparency of healthcare institutions about when things don't go right, and accountability. And that's a scary prospect, especially when you're looking at like being sued, right? But what I find in dealing directly with mothers and families, a lot of times they just want someone to acknowledge their experience and say, I'm sorry, instead of just, for the sake of covering themselves, in litigation, just pretending like nothing ever happened. And so I'm curious to have a better sense of different institutions, what their near misses are, what are the instances in which things went wrong, and so that we can then work together holistically to find ways to reduce those kinds of experiences and heal as a community.
Absolutely.
I'd like to comment to that, Trevor, can I?
Yes, of course. Yes, Dr. Trigo, please.
Yeah, so Nakina, I think you're referring to maternal mortality review committees, and that is also something that needs to be, so first of all, we need to have a national maternal mortality review committee. And that's not as far weird as it sounds, because they do it in the UK. Okay, so they do it in Europe. So there are national level maternal mortality review committees. In order to have that, you need to have state level maternal mortality review committees, so that the state reviews on an annual basis all of the deaths that are maternal related deaths. And then they do root cause analysis for every single one of them. And they try to figure out what is contributing to each one of those deaths. And then if you can pull the state stuff together on a federal level, you'll get a better sense of what our entire nation's healthcare system is doing that contributes to maternal mortality. And we also need to add into the severe maternal morbidity, which we haven't talked about, but that was the cause of death in the video. And it was also, that's what Serena Williams had, severe maternal morbidity. And those are the near miss cases that Nakina is talking about. So we need to see where those severe maternal morbidity outcomes are. And that's like you need blood transfusions, you have a high blood pressure incident, those types of severe maternal morbidities, illnesses need to be tracked. And we need to figure out how can we not even have those near misses.
Thank you for adding that, Dr. Trigo. Thanks so much. Nakina, did you have a bit to add there?
I would certainly agree. I know y'all have the videos, but I would just say with my second pregnancy, I had a traumatic birth experience. My son had a shoulder dystocia, and then I suffered from hemorrhaging after delivering. And I had preeclampsia and, postpartum hypertension. And there were some things that I felt like could have gone better throughout that experience. And one of them was that postpartum, I was given a medication for my hemorrhaging that has a side effect of elevating blood pressure. Well, for a person who has pregnancy-related hypertension and preeclampsia, that was not the move, right? And so talk about near misses. And I would like to say that I'm an anomaly, but in my circle of mostly master's and PhD educated Black friends, I could throw a stone and hit all the women who have had similar experiences. And so, but there's nowhere that's really capturing and telling that story. And so it's easy to just, keep it at bay, but these are people's lives, right? That was my life. So when we talk about near misses, I just wanted to interject that.
Yes, and thank you for doing so. I'll stick with you for a moment. Your program that you briefly mentioned at the top with Black Mamas Community Collective, your doula program. I'd like to hear, we're going to transition a little bit into maybe an avenue of successes and maybe kind of what that looks like and what you've seen in your respective fields. But Nakina, can you tell us a little bit about some of the outcomes of your doula program?
Absolutely. So we, as you mentioned at the top of the program, we've only been in existence virtually functional since the beginning of 2018. And we began to pilot a home visiting program and doulas mid-year of 2018. But during that time, we have seen significant success in our home visiting program. And it's important to note that we start with our moms prenatally. We are there for birth support, and then we're actually with our moms for the entire first year postpartum. And during that time frame, we are looking at and periodically administering the postpartum anxiety and depression scales, as well as social support survey and racial microaggressions. And we're tracking that, and we're resourcing out, making referrals out in addition to the support that we provide. But I wanted to quickly give you some of our outcomes to date. So the national African American C-section rate is 35.3%, and Black Mamas ATX has a C-section rate of 12%. Our preterm birth rate is 4.9 in comparison to the national statistic of 16.5%. Our low birth weight rate is 5% in comparison to 13.3 nationally. And then we're extremely proud of this. We have 100% breastfeeding initiation rate in comparison to the 69.4% rate nationally. And even at 3 months postpartum, our moms are still 88% of our moms are still breastfeeding in comparison to the 58% nationally.
Those are some terrific successes to share there, and thanks to the hard work of you and your entire team. Scott, when we're talking about kind of successes from the faith-based perspective, from these really super hyper-local grassroots efforts, what are some successes that you have seen or that you're hoping to see through this kind of effort?
I think the success over the course of the last 2 years, especially on this issue, is that there are groups like Circle Up and others who are making it a priority, and many legislators are now talking about it kind of openly. There are a couple of legislators who every time we talk to them bring up this topic. But I think that especially in this legislative climate, that leads us maybe to a homework assignment, which is in a legislative session where folks might not be able to meet in person. I think it's vitally important right now that groups start meeting with their legislators either by Zoom or in person if they're requiring it. But start having those conversations right now, like in the next 2 weeks, and try to figure out how you're going to be able to stay in contact with them during the legislative session if you're not able to go in person. So figure out whose cell phone number you need, who the appropriate person in the office to talk to is. And some groups have started that work, so I'll list it as a success. But for those who haven't done that yet, the time is now to start figuring out how you're going to be able to work with members during a potentially physically distant legislative session.
Excellent point, especially as we enter a really unusual session. Thank you for those tips. Dr. Trigo, I'd like to ask you a couple of questions. I would like to talk about what success kind of, as we start to maybe move the needle, what that does look like. I did have a question though about when we're talking about women's healthcare and in particular this issue, what does that look like what does that work look like when it enlists? So when we're taking this into the military context, I am kind of personally fascinated, maybe some out there are as well, as what does this story look like in that context, and how does it differ, or does it?
Thank you, Trevor, for asking that question. Given that I was a military midwife for 20-some years. So there is a section in the National Academy's study report about it gives a couple different examples of systems that do work. So the federal healthcare system is one that has better maternal mortality outcomes. And the military, the DoD system is part of the federal system. And so federal could be VA and the DoD are the federal healthcare systems, the two largest ones. In the military system, we have combined, we basically have team care. So team care is something I didn't mention here, but team care is incredibly important in all settings, but mostly in a hospital setting. So team care is where nurse midwives and physicians work side by side and collaboratively to take care of the women. So yes, you might be a midwife patient, but trust me, if something goes wrong, or if you step out of the realm of normal or low risk women, which is who midwives take care of, we have our partner physicians right there to consult with and to provide the proper care. So, it's, for example, if you are all of a sudden everything was great and all of a sudden your blood pressures are sky high, we don't just say, well, let's just relax a little bit and take it later and see what happens. We'll go right to our partners, our team members in care, and say, hey, we've got to address this blood pressure issue. And at that same time, we aren't threatened by the loss of the patient because we don't lose the patient to the obstetrician. And so we can all work together to do the best thing. And when the patient comes, or the woman comes out of the high-risk situation, she may even come back to midwifery care, or we continue the care together. The important part about this team care and this team atmosphere in military healthcare is that we do not have insurance companies or reimbursement at the heart of what we do. Nobody cares, okay, because the care for the patients is going to happen anyway. Nobody cares, meaning this group of professionals doesn't care about getting money. This group of professionals doesn't care about losing money because, well, first of all, we're all getting paid the same because we're all in the military. But our hospitals aren't being reimbursed in that manner either. So there's no insurance involved. And that is a very good way of looking at federal health care as, it's a single party payer system. There are no other implications for who does the birth and who doesn't have the birth. And was it a cesarean section? Because that makes more money for the hospital than a natural, than a vaginal delivery. So those things are taken out of the situation. Honestly, when I retired from the military and I started to learn how things worked in the civilian healthcare system, it was very eye-opening for me. The good news is I know how it can be. And then the good news is we are working on models, demonstrating models that do work in that manner, that can show that we can provide team care and have better outcomes. Value for performance pay models are a success because having a cesarean section isn't valuable. That's not value-based care. So you won't get reimbursed anymore for that. Those are examples of how we can change the scenario and make it better for women, for their outcomes for women, not financially for providers or healthcare or hospital systems.
I find that so interesting. So then do you find a difference in the data then in terms of morbidity and mortality in military maternal health care then?
Yes, we have a lower mortality rate. And we have to report the same things that everybody else does. So we have the same reporting mechanisms, but we do have a lower maternal mortality rate as of 2018, I think. I don't have it right in front of me, but it's in the report, in the National Academy's report. There's a whole section on it.
Wow, that is fascinating. So then is it fair to say then that the civilian healthcare system really could have a lot to learn by the models that we can find in the military healthcare system?
Yes, and that is why the committee, this is a consensus committee, that is why they included that in part of this report.
Wow, thank you for sharing that. I appreciate that. That's really interesting information. Nakina, you started us off in terms of the success conversation with that incredible information from your doula program, which is really to be applauded, and I'm sure everybody in our attendees and our panels are. What are some other successes, and what does success look like when we're talking about your specific mission with Black Mamas Community Collective here in Texas and in Austin? What are successes that you really want to see?
So for us, the most recent data that we have that was from 2012 to 2015 puts Central Texas as having the highest maternal mortality rate in the state at 62.1 out of every 100,000 Black women, which is, mind-blowing considering, and Trevor, this, that Black folks in Austin are about 7% of the population. So when you line that up beside Dallas, Houston, and San Antonio, it's even more alarming. And so for us in Central Texas and Black Mamas ATX, Black Mamas Community Collective, what success looks like for us is knocking down that mortality rate. And I believe that collaborative work is the only way that we're going to be able to get it done. So right now, Black Mamas is having a lot of conversations and meetings and planning with our multiple healthcare or hospital systems here in Central Texas, as well as a couple of the managed care clinics that serve patients here in Central Texas. We are also working alongside of advocacy organizations like Texas Children's and Texas Women's Healthcare Coalition. And not only that, but we have a maternal health equity collaborative that is actually 4 of the local doula organizations, both Black Mamas as well as Mama Sana, Vibrant Women, Healing Hands Community Doula Projects, and giving Austin labor support alongside of Hand to Hold, which works with NICU families and Partners in Parenting. We have created this collaborative that we hope will form a safety net to where we're not, looking individualistically at how our organization alone, or how that particular hospital or private, physician is going to move the needle, but how can we do it by working together? So that's what success looks like to me, that we see those numbers decrease. And, on a more intimate level, that when we are interfacing with our mamas, we hear that they have joy and hope in their experiences and bringing children into this world.
Thank you, Nakina. And I know we are going to chat a little bit about next steps and ways to get involved with Circle Up here after our discussion. I did want to thank you all very much for joining us today. Your perspective is so valuable. I wanted to just real quick before we wrap up in the next couple of minutes, Dr. Trigo, I did want to retouch on my question in terms of looking at the big picture from the medical professional side of things. When we're looking at needle, what are the most important successes you're looking for to know that we are kind of moving that needle?
Well, in order to know that we're moving the needle, we need to see a decrease in our maternal mortality rate. So we need the nationwide maternal mortality rate to go down. That's the bottom line. It's unacceptable that our maternal mortality rate is so high to begin with, and it's got to go down. And pushing the needle is really looking for a system-wide change. All of the things we've discussed today are all critical parts of the system. But, even to the point of getting white men involved, I mean, I would go all the way up to, I'm going to say it, we need a federal way of improving the system. I don't know what that looks like, but putting things together, a little bit here and a little bit there. There are such good success stories throughout the nation that we need to capitalize on them and create a cohesive system that looks at, just like a federal or a nationwide maternal mortality review committee. We need something that is that big to influence and make the changes all the way through the system, down to those poor, underserved or rural areas that don't have any health providers. You see, you need the big system in combination with all of the other demonstrations that show that things work.
Absolutely, thank you. And to kind of end our moderated time together and transition into this next steps, ways to get involved, Scott, I will ask you, because UMW and Circle Up is doing such a great job. If there is a congregant out there, somebody who is watching this or will see this, and they want to know, how do I even begin a conversation with at the very local level in my congregation with my pastor or my faith leaders about raising up this issue in the congregation, what are the best ways to go about that?
Texas Impact has resources. We have treasure hunts. We have legislative engagement groups where we connect people from other faith communities together. We're happy to work with local congregations to try to get something up and running. You can reach out to me at scott@texasimpact.org, and we can try to connect you either with other people in your faith tradition or other people in your community who are doing similar work, or provide some tools that we have to help congregations walk through that process.
Excellent. Thank you so much, Scott. And thank you to all three of you for sharing your stories and your expertise today. It has been such an enlightening conversation, and I hope that is the same for our attendees today. This will wrap up our moderated portion of the program. I am so grateful for the work that you are all doing, and I really feel like it was a privilege to be able to have this conversation with you today. So thank you very much for your time.
Thank you.
Thank you too. I enjoyed it. Nakina, I think I want to connect with you, and so I'm going to get your information.
Hey, girl, you got it.
I love that.
Well, thank you all so much. And thank you, Trevor, for so skillfully leading that panel. That was just full of interesting information and perspective. that I know I found will inform my work going forward. And I hope that many of our attendees will as well. We are going to pivot the program in a minute to look at next step ways that people can get involved. But before we did, I did want to share one more personal story. This is another video that was created as part of the Council on Patient Safety and Women's Healthcare's Voices of Impact series. And so I'm going to go ahead and share that, and we will watch this personal story, and then we will talk about next steps after that.
My husband and I met when we were 8 years old. We were in Mrs. Anderson's 3rd grade class, so we've known each other for over 25 years.
We went to the same elementary, middle school, high school. We went separate ways for undergrad, and I reconnected 2 or 3 years after we graduated.
It was just like one of those things, hey, let's hang out, let's go out together, and we did. I was with my girlfriends, and he was supposed to bring his guy friends, but he showed up by himself, and just from then on, he's never left my side. We realized that we had so much in common. We loved to travel. Our goals just aligned in life, like what we wanted our family to be like, and where we wanted to go. So he was the perfect partner. And when he finally proposed, both sides of our family were ecstatic, and the wedding was perfect. We even had Mrs. Anderson, our 3rd grade teacher, there.
It made for a very unforgettable experience.
When I found out that I was expecting, we were thrilled.
It didn't really set in because it took like 3 years, I think, because we struggled with it.
We waited until Mother's Day to tell our moms that they were going to be grandmas. I found out that I was in labor when my water broke at 3 in the morning on December 23rd, and that's when the charge nurse checked me and I wasn't even dilated. We waited a little bit longer. I got to 2, and they finally said, okay, we're gonna start you on some Pitocin. So after 32 hours of labor, they're like, okay, we can do the C-section. So finally they came in, and it was 11:45 p.m. Christmas Eve. And from there, they took Penny out. She came at 12:13 a.m. and we were thrilled. I can't even explain what was going through my mind, but she was here. I heard her cry. We waited so long for her to come, and all I could do was stare at her, and the nurses took her, and I'm looking to the side and watching the nurses take care of her, and I'm like, what's her score? I want to know if she's healthy, and she was perfect. And they said that it would be like a slight massage, and they put everything back and sew you up, and that's that. So I'm laying there like, okay, this is not the massage that I was thinking that it would be, because my body is moving back and forth, and all I could think was like, this is not normal. And I started to feel cold and started to shiver, and all of a sudden I felt like I wanted to go to sleep.
I remember thinking to myself, like, this is taking a long time. And I remember near the end, Jane was in a lot of pain.
Through like my peripheral vision, I can see a bunch of doctors rushing in.
And the nurse came to me and was like, hey, do you want to go with your daughter, or do you want to stay? And then I remember asking Jamie, he's like, do you want me to go with Penny, or do you want me to stay? She's like, don't leave. At some point I heard something about the bleeding and trying to stop the bleeding, and I'm like, oh God, what's going on? She's like, I don't want to die. And I'm like, of course, I don't either. And as soon as she said that, I remember looking down, and I had to look away because I couldn't show her that I was concerned. On the inside, I was so scared. She's asking me, am I okay? Am I okay? I'm like, yeah, you're great, you're great. I couldn't show her in my eyes that I knew something was wrong. And I remember looking down because I had to look away. I couldn't look at her at that point. And I looked to my right and I looked down, and I remember seeing this bucket, and it was full of blood. And I was like, that's when I knew like something was really, really wrong. When I saw that, I knew that it was a blood issue. The hand she was holding of mine, I've never felt her squeeze my hand that hard. And I knew that whatever they were doing must have been hurting her a lot. I looked at the ground in the same direction I did the last time, and now the thing was full, and it was all over the floor. And they asked her, like, do you want a blood infusion? And they're telling me that she lost half her blood supply, like she needs one. Thankfully, whatever everyone did, all the doctors did, it worked. It absolutely worked. And I'm over the moon thankful that the outcome ended positively. And after that all was done, they took her out to ICU.
The first person that I wanted to see was my mom. I was traumatized because I didn't have my baby, and you know, you just want your mom's touch and that hug and kiss to tell her that everything's gonna be all right. And even though she was saying that I was going to be okay, I didn't believe it.
She broke down. It really hit home for her at that point.
The first time I got to hold Penny was a day later after being in the ICU, and I remember her putting her in my arms and thinking like, wow, like this is really mine.
It's just so natural because she just curled up crying on Jamie's chest, and just everything about it was right. I was so excited to finally go home and enjoy being a new family of 4, because we count Teddy as our firstborn.
So the holidays have a different meaning for us today. It's not just Christmas, it's not just Penny's birthday, but I survived. I got to become a mom. It's one big celebration of getting to experience this. I think about that time where I was in the ICU and that I almost wasn't her mom, and how lucky we are to be there for Penny.
Okay, so Jamie's story as well as Shalon's story, both very powerful stories. And again, we wanted to include these personal stories as part of today's program to just emphasize that these are real moms and real people. And there are personal stories that belong to these statistics. And so the statistics are, as we talked about during the panel, are so important to know and understand. But I know that personally, myself and many members of Circle Up feel really called to work in this area because of mothers that we, either our own birth stories, mothers we know, mothers we've met along this journey in advocating in this area, who are real moms with real kids and real families. And so there's really a place for a real impact to be made. So speaking of that impact, we're going to turn our attention for the last little bit of this program to what next steps you can take yourself or with your own faith communities to start advocating in this area. And so we wanted to start with a poll question for everyone. And so if you could take a minute to enter in the poll, what is an important lesson that you will carry with you as you engage in this work? And you can select all that apply. And then also we wanted to see if you in the chat box could enter at least one thing that you plan to do to engage in this work moving forward from this program. I'll give everyone a minute to. Okay, great. So it looks oh gosh, the numbers are always jumping around. It's hard to gauge them, but there's a lot of interest in all of these, that maternal health is affected by many factors. Improving access to maternity care is important, especially for rural areas and communities of color. Expanding Medicaid to 12 months postpartum is an evidence-based policy solution to improve maternal health outcomes, and reducing racial inequities in maternal health outcomes will require attention to social determinants of health, in addition to ensuring appropriate and high quality maternity care. And looking at the chat, I'm seeing that people are ready to reach out to their legislators. I'm so pleased to see that. I think that when we first started this work, our home congregation happens to be located physically right across the street from the Capitol on Lavaca Street in Austin. And going just over to the Capitol to reach out to legislators seemed so daunting. But it's really not. They're just people, and your input is valued. And so I'm really pleased to see in the chat box that a lot of people are planning to reach out to their legislators, as well as inviting and recruiting more people to advocate in this area, reaching out again to legislators, continuing to educate our especially male partners and friends. These are all great ideas, and I hope that everyone will leave feeling equipped to take on a new avenue of this work. So with that in mind, we did want to highlight a few ways that you can take next steps. And so I'm going to go ahead and share a document with you all that, here we go. Looks kind of summarizes some opportunities that are coming up, some specific opportunities. And the first thing in the avenue of trainings is a groundwater analysis training that will be taking place this January 29th and 30th from 9 a.m. to 3 p.m. And this is a workshop that will be facilitated by Joyce James, where she utilizes her groundwater model as a basis for analyzing and understanding racial inequities and the role that communities of faith can play in dismantling systems of oppression. I had the opportunity to participate in this training about a year and a half ago, and I just cannot say enough or emphasize enough what a wonderful opportunity I think that is. It was very, very formative for me in informing how I move forward with this work, and also just how I look at a lot of different systems. So I highly, highly recommend taking advantage of this opportunity. It's going to be offered via Zoom, so you don't need to be in the Austin area to participate in it. And it does have limited availability, so I would recommend signing up sooner rather than later. And one thing that I wanted to mention is that we will be providing all of this information in a follow-up email to our participants, and it will include links that you can sign up for some of these opportunities, including this training. So I really hope a lot of you will take advantage of participating in that groundwater analysis training. Other events that are coming up, Circle Up will be hosting a legislative postcard campaign. We did this last session and had a good response from the legislators to this campaign. And so we will be sending a postcard to every state legislator's office, providing them with some information on maternal health statistics and a handwritten note asking them to prioritize maternal health issues this upcoming legislative session. Texas's next legislative session will begin this coming January and run through early spring. And so we are looking for people to help us write these postcards. We will provide more information in our follow-up email about how you can sign up to help with those. And then really all you have to do is just provide the note, and we will make sure that it gets to the legislators. And it's a really great way to get your voice heard over at the Capitol and let them know that the people of Texas and people of faith in Texas really want them to prioritize maternal health issues. Texas Impact and United Methodist Women will also be hosting a legislative event in January. It's a virtual event that goes over advocacy at the Capitol with the legislature and topics of interest. And so it's another great opportunity to learn more and gain more tools for that advocacy toolbox. And then there's a couple sources of information I would encourage you to look for as well. One would be the Texas Maternal Mortality and Morbidity Task Force Biennial Report. This is a report that Texas's Maternal Mortality and Morbidity Task Force issues before every legislative session. It was meant to be released earlier this fall, but due to the pandemic has been delayed, and we anticipate that it's going to be released in early December, just in a couple weeks. And so that report will have updated statistics and information that the Capitol will receive, but also should be a good source of information for sort of the numbers state of things in Texas. And so we'd encourage you all to look for that. We'd also encourage you all to sign up for our e-news mailing list. We use that list to send out information events that some of our peer advocacy groups will be hosting, as well as our own opportunities to get involved, calls to action that we will send out during the legislative session to take action on specific pieces of legislation that we are trying to support, and things of that nature. So I encourage you to sign up for that list if you haven't already. If you do not know who your Texas legislators are, I would encourage you to go to the website listed and look up who your legislators are at the state capitol. Again, with the session coming up, it's important to just reach out to your own legislators and let them know, I want you to prioritize maternal health. This topic is important to me, and I think that you should prioritize it as my representative or my senator. And so I'd encourage you to equip yourself with that information before the session starts, and just familiarize yourself with their phone numbers and email addresses. And then there's also a couple social media resources and groups that we would encourage you to follow. In addition to our own accounts, we are big fans of Texans Care for Children. They do some really great work in this area. Of course, Black Mamas Community Collective. We have learned so much from their work, and they, as Nakina told you during the panel, they are doing amazing work in this area. And so I highly recommend following them and getting informed about all the work that they are doing. And then Every Mom Counts is another organization that looks at things on a more big picture view, but is another great organization to follow. So as I said, we will be sending you a follow-up email that contains all of that information with links to get to sign up for all of it. But as we draw to our close today, I did just want to say a few thank yous. Of course, first of all, I wanted to thank our three panelists. They were so wonderful in providing their knowledge and their perspective. And of course, our moderator, Trevor. We super appreciate all of you guys taking time to spend with us today. We also wanted to thank the Council on Patient Safety and Women's Healthcare for providing those personal story videos that we shared. They were a really great resource for us, and we just appreciate them making them available for use to continue to raise awareness on these issues. We'd like to thank the United Methodist Women organization and First United Methodist Church Austin for their support of our work and support of this event. And we would specifically like to thank Black Mamas Community Collaborative, specifically Joyce James and Nakina Wilson, who both provided some input and feedback in the planning stages of this event that was very helpful to us. And so we super appreciated that. And finally, we wanted to thank all of you for being here, for joining us, for taking part of your precious weekend to learn about this issue, hopefully get inspired and motivated and empowered to take action yourself and your faith communities. We so appreciate you joining us. And with that, I will give you back the rest of your afternoon. Please feel free to follow up with any questions when you receive your summary email. And I hope you all have a wonderful rest of your day. Thanks so much.